All right, good morning, everybody. We're going to run through some CE here for airway. We're going to do a little refresh on airway and intubation and kind of airway management in general. And then we are going to introduce the Bougie, which will be rolling out within the system for use in the coming weeks here. So we'll go ahead and get started. So just kind of going through our objectives real quick. We'll talk about a little history of the advanced airways. We will give a few tips and tricks in regards to the intubation procedure. Obviously, we'll introduce the bougie and kind of different options in regards to using that. So looking at some history here, so the kind of supraglottic devices have changed quite a bit, even in recent years. We started out here with the combi tube. We moved on to the King airway, and then now the iGel is kind of our first line in regards to the supraglottic type airways, which kind of eliminates the balloons and things that we're familiar with to try to protect against aspiration and different things there. The iGel is much easier to place and it doesn't require any inflation or anything. But unfortunately, that is at the cost of a bit higher of an aspiration risk, and it's obviously a bit higher of a chance of it getting dislodged as well. Um, it does come with that kind of elastic band that's used to hold it in, but when we're doing things like compressions or moving the patient or moving from the ground to the cot or the cot over to our cot when you get to the ER, it is a bit higher risk of getting that dislodged. The ET tube, however, hasn't changed. We have the same ET tube that we've used for quite some time. It works and we haven't changed it. There we go. Video, that is what most of us are using now. There's a variety of different ones. So far within our system, we have not mandated any specific video device to use. Whatever your system has is appropriate, as long as you all are comfortable using it. Just a few examples here. We have the McGrath, we have the AirTrax, and then we have the ProView, which is a little bit newer of a device. For the videos that we're going to be showing in regards to intubation and stuff on here, we'll be using the AirTrax device, which was loaned to us for use to be used for this demonstration. But again, whatever device you guys are carrying on your rigs is appropriate at this time. Talking about iGels versus ET tubes or supraglottic versus the glottic devices, mixed bag on the data. There are some sources showing that there's really no difference between the iGel and an intubation, and then some studies are showing that there is increased ROSC rates in patients that are truly intubated versus using a supraglottic device. There is a higher rate of aspiration when using the supraglottic type devices because it doesn't truly secure the airway. With the older devices like the combi tube and stuff, you do inflate that balloon, but it still doesn't completely occlude the trachea from getting any aspiration or stuff like that inside of it. And then obviously, like I had talked about before with the iGel, it does not completely, it doesn't have any balloon. So there is a risk of aspiration, especially if that dislodges slightly from where it's placed in the first place. This study is talking about slightly increased ROSC rates with ET tube intubation. It goes from about 28% up to 33% on patients that are intubated versus using a supraglottic device, which is highlighted down here. Obviously, the N number is pretty small in this study, but it does show a little bit of improvement, which is encouraging. And then this is kind of just what I've been talking about on these slides recently. This is showing an iGel device and kind of where it sits within the glottis and the opening down there versus the ET tube. With the iGel device, you can see that it goes in. There's no balloons. There's nothing else. The idea is that it occludes the esophagus at the tip over here. And then the air exchange portion of the tube lines up nicely with the trachea. Unfortunately, everybody's anatomy isn't perfect, and it doesn't look exactly like this. and this does lead to those increased risk of aspiration on occasion. Whereas the ET tube directs the air exchange directly into the trachea, you then inflate the balloon at the tip of the ET tube, which theoretically then is not allowing any of the esophagus contents to backflow into the trachea, leading to any aspiration risk or anything along those lines. So within our system, our current position on ET tubes and airway management is that endotracheal intubation is the gold standard, and this is because it does protect against that aspiration risk, which is associated with worse outcomes for the patients, and infection and things along those lines. There are other areas in our system that are using an I-gel as first line in cardiac arrest patients. At this time, we are not going to go that route. We will continue with endotracheal intubation as our gold standard or first line in those type of situations. I-gel can be used, however. We're not saying you can't use it. It definitely is a good device in a lot of situations. There are a variety of reasons where you may choose to use an I-gel first of all. And this would be A, if you can't place an ET tube, you can move on to an I-gel as a kind of a backup device. B, if you don't have enough manpower, so if there's not enough ALS trained staff at the scene to kind of get everything set up and everything that you need for the intubation, an I-gel is appropriate second line in that type of situation as well. Or if you attempt intubation and are unable to pass it, or there's bad anatomy or things along those lines, you can absolutely use an I-gel in that type of a situation as well. But we still do recommend endotracheal intubation as our first line in those situations to at least give it a shot to protect against the aspiration risk. Laryngoscope, I kind of covered this when we were showing the pictures before, but essentially our position is whatever you are most confident in. So direct versus video. I do highly recommend video though if you are carrying it. It can't really hurt. It does increase your chances with that video aid, kind of showing exactly what the tip of the blade is looking at over there. It does increase the first pass success pretty significantly with intubation. There you go, 20% higher success rate than a direct intubation. So talking about goals for the system as far as intubation success rates versus first pass success, our goal for the rest of this year going into next year is a 60% first pass success, which is about 10% higher than where we're sitting right now, and then an ultimate 80% success rate with ET tubes, not necessarily on the first pass, which is a bit higher. We're currently sitting somewhere around, I think, 67%, 68%. So the goal is to get that up to 80 by kind of refreshing a little bit of the technique and then adding in the bougie as an opportunity to increase your success. So kind of talking through the setup a little bit here. Make sure you have all your equipment ready. Obviously that kind of makes sense. You guys carry a kind of an intubation kit in regards to all the equipment that you need. And then moving on, you should always use suction. Always should have suction ready to go on these intubations. You can do the salad technique. You can suction before you go in. But leading with the suction catheter, i.e. the salad technique, is definitely appropriate to kind of clear the airway of any vomitus or blood or anything else that may be in there, which will increase your success. And then using this technique as well kind of helps you to get a tracheal intubation, because if the suction catheter is kind of placed by the esophagus to suction any of the vomit that's coming, that is kind of giving you a bumper to prevent the ET tube from going down into the esophagus there as well. Sniffing position is appropriate for all patients unless contraindicated. Obviously in trauma situations where there's a C-collar or cervical precautions, you're going to want to avoid manipulating the neck as much as possible. Otherwise, a sniffing position is a great start. And then make sure you have somebody by you that can kind of hand you things within need, or have everything sitting within a couple inches of you on the ground over there, so everything is within reach and you're not needing to get up or reposition yourself or do anything to get something that wasn't there, like a stylet or a bougie, etc. And then having the right mindset, having the mindset of we will get an airway, being confident in your ability in getting that intubation completed, and not necessarily having the mindset of we need to get this airway right now in a couple seconds. Staying calm and kind of walking your way through the intubation slowly and cautiously is going to give you a higher success rate than thinking, oh, I need to intubate this patient within a couple seconds here. And then a lot of times you kind of panic and don't necessarily get the tube exactly where you want it to go easily. Tips. Lubricant is important in the intubation setting. You can lube the blade. You can lube the edge of the tube, especially by the balloon. That helps it pass through the cords, and then lubing the bougie as well. I know this is kind of an added step and takes time, but if you have some lube and just put it on your finger and put it on those areas, it only takes a couple extra seconds, and it definitely does increase your success rate to prevent you from getting hung up on any of the anatomy as you're advancing your blade and the tube or the bougie through that area. Suction catheter, we talked about that before. You can leave the tip of the catheter in place by the esophagus to prevent any aspiration, and that also gives you kind of a bumper to kind of prevent the ET tube from going into the esophagus since that is positioned in there. And this kind of shows an example of that. So if the suction catheter is down here in the esophagus, that's A, preventing any aspiration by suctioning the contents as they come up, and B, that's giving you a little bit of a blockage, if you will, so the ET tube will go where you want it to go, and then you know exactly where the esophagus is and how to avoid it. And then a light grip on the laryngoscope handle is appropriate as well. Squeezing it really hard, pulling, pushing, things like that. You're not necessarily trying to move the anatomy out of the way. You're trying to work around the anatomy that's existing. So a light and soft grip and kind of following along the anatomy that you see as you're going is going to give you more success than just trying to manhandle the laryngoscope and the ET tube through. This is an anatomy refresher. This is a great view. That would be awesome if you could get every time as you're going through these intubations. Just a little bit of refresher here. Number one up on the top is your epiglottis. The arytenoid cartilage is kind of the V-shaped underneath the cords that you see. Obviously the vocal cords are your white and glossy things in the middle. Which obviously in pediatric patients, they are not going to be as white. They are more pinkish in color, which just continues to add to the increased difficulty of the pediatric airway. Interarytenoid notch is right in between the arytenoid cartilages. Trachea, there's your goal in the middle, right in between the vocal cords. And then you have the recesses on the side, the piriform recesses, and the aryepiglottic folds at the top of the airway over there as well. So finding this view, finding the midline when going down the tongue and the epiglottis will help you to kind of progressively identify these landmarks as you're going, which will assist you in finding the appropriate anatomy in a successful intubation. So when using the blade, you're going to activate the molecular fold over here, which essentially when you push the blade into that, it's going to lift your epiglottis up and give you this view that is seen on the right, where you kind of expose those vocal cords and gives you a nice target to go ahead and intubate through. If you go too deep, it kind of blurs your anatomy. You just see a whole lot of pink tissue and saliva, and you can't find the tube, or you can't find the cords or your epiglottic opening. So if you find yourself in this type of a situation where you see some of the esophagus and things like that, pull your blade back, and a lot of times things will kind of just pop into focus there as you kind of back up enough to visualize the anatomy that you're looking for. Secure the tube and then verify placement. One reason for failed airways is actually if you don't inflate the cuff before you pull out the bougie or the stylet or whatever it is you're using. A lot of times you can inadvertently dislodge the tube before that balloon is inflated. So once you visualize the tube going through the cords, go ahead and inflate that cuff and then pull out your stylet or bougie or remove it from the track on the side of the laryngoscope blade to make sure that tube is secure and doesn't accidentally get dislodged. And then obviously every time that you check that the blade is placed, you're going to go ahead and recheck it and make sure that balloon is inflated. Slow is smooth, smooth is fast. This is kind of what I was talking about before. Don't rush the airway, stay calm, move through it step by step. You can kind of verbalize your anatomy as you're exposing it. Keep a nice light grip on that blade, and then go ahead and pass the tube through. And just kind of staying calm and doing things slow in a controlled setting is going to increase your success rate there. So our algorithm for airway, obviously the most minimally invasive is what's going to come first, which is your oral or nasal airway. After this, we're going to move on to endotracheal intubation, which will secure your airway, prevent aspiration risks, etc. If that is not possible for whatever reason, a supraglottic device such as the iGel would be your next step. And then the final step is your surgical airway. If you are unable to complete any of the above, if you can't ventilate the patient, then the crike or surgical airway would be your next step. Now moving on to the bougie. There are multiple different ways to use the bougie, and ultimately whichever is most comfortable for you is what you're going to want to use. So you have essentially going from top to bottom here, you have the preload. This is where you're going to use the channel blade. You will put your tube and the bougie and the channel blade on the laryngoscope. You'll have the bougie advance just slightly, so you can see it on the camera. You'll go ahead and push that through the cords, and then advance the tube from there. You also have the middle, which is your naked bougie, which is essentially where you're only going to use the bougie. You're going to get that through the cords and then kind of railroad the tube over the top of it. And then the final one on the bottom is the loaded bougie, but still kind of working with a naked bougie in what you can visualize. This is kind of a combination of the two. So this one allows you to pass the bougie and gives you the most flexibility of the bougie itself. But that tube is already preloaded on there, so when you go ahead and advance it, it's a little bit more smooth and you don't need to kind of thread the needle anymore. That part's already done. This is another technique that can be used. To be honest, this is not a technique that I've used, but it is one that's taught, and it kind of gives you a handle essentially. This is very similar to the preloaded bougie, but you go ahead and fold it and then put the edge of the bougie through the hole at the end of the ET tube, and this gives you a handle at the end that you could use to kind of rotate and pivot the bougie as you're advancing it, and then you go ahead and disconnect this through the hole once you get the bougie through the fold or through the vocal cords, and then advance the tube from there. The only caveat to this is it generally only works with bigger tubes to kind of fit through that hole at the tip of it there. If you're using a smaller ET tube, the hole isn't big enough for the bougie to pass through it. But this is kind of a better example. So this whole D, or kiwi as they call it, at the end kind of functions as a pivot point or a handle that you can use to manipulate the edge of the bougie, the distal tip, as you're going through the vocal cords or trying to find the area. So as far as using the bougie, it's not required. If you're comfortable using the ET tube and stylet that you are right now, you don't need to use the bougie. We're not mandating it. We're not making it something that needs to be used on every intubation attempt. I think after a lot of you practice with it and use it, you are going to want to, because it does make things a little bit easier, because the tip of the bougie is much easier to pass through the vocal cords, especially in the more complex airways. So I think it's going to be an excellent tool added to the tool bag, but you don't have to. It's whatever you're most comfortable with as you're doing things, but I do encourage that you at least try and practice with it. After a first pass failure, it is highly recommended to use as kind of a backup plan if you didn't use it in the first place. Now, if the first attempt failed because there was vomit and you suction the vomit and now you're good to go, you don't necessarily need to in that situation. But if it's a failed attempt because you could see the anatomy but aren't able to pass the ET tube, the bougie would definitely likely help you in that type of a situation, and it's highly encouraged that you would use it at that time. Documentation, so essentially just click the right box. If you're using the Bougie, use the one that says we used a Bougie here. Now, if you're using like the portable glide scope device or something with a stylet, we will be adding a box with the appropriate verbiage for stylet associated intubation, just so we can distinguish Bougie as we're kind of looking at the numbers here and seeing how things go.
Hello again, everyone. There's a new power tool in the ALS dash for video intubation with a Bougie successful. So as I said, it's in the ALS dash situation tool. Scroll down and find it. There it is. And there are a lot of choices that have already been made for you. Tube size needs to be filled in. The laryngoscope blade prior to arrival is still set to blank, but confirmation, who did it, tube depth, and what the anatomical location of the measuring was, and the confirmation methods, along with the new airway Cormac-Lehane glottic opening field.
Bougie as we're kind of looking at the numbers here and seeing how things go. Where to go from here? So practice. So we recommend practicing this on multiple occasions. The minimum is 10 attempts. Use different techniques. Try it with all the different grips and preloading and the Kiwi grip and things like that, and kind of see what flows best for you and what feels most comfortable in your hand. Use it with both direct laryngoscopy and video laryngoscopy. As far as competency goes, you'll be checked off and approved when you perform 3 consecutive successful first pass placements using both video and direct intubation techniques. And then as far as an agency, you'll be approved when 100% of your staff have trained and checked off. Now, obviously, if people are on vacation or PTO or things along those lines, they will need to be tested and trained on their first day of return. So that is our refresher.
We're going to demonstrate the basic techniques of salad here. My assistant is filling the mannequin with simulated airway contaminant. We're using that's good enough, James. It's simulated airway contaminant made from a concentrate for artificial blood from the Simulates NASCO company of United States. I'm going to start with an overhand grip, and what I'm going to do is simultaneously evacuate the airway contaminant from the pharynx of the mannequin, and I'm going to use the suction as a tool in order to distract the lower mandible, contain the tongue into the floor of the mouth and into the thyromental distance of the mannequin. This is going to allow me to do an easy insertion of the laryngoscope blade, hugging the base of tongue, staying above the posterior pharyngeal wall, staying above the palate, so that I allow gravity to have the residual airway contaminant pool to the gravity-dependent posterior pharynx. If I scrape the posterior pharyngeal wall as I'm coming around the base of the tongue with the laryngoscope, what will happen is I'll pick up airway contaminant, in this case artificial blood, onto both the light source as well as the video source, and I'll have to stop, remove that, wipe that off, and begin again. As we know, in emergency airway management, time is critical. I'm going to show you some techniques to save you some substantial amount of time. I'll begin now by focusing on the oropharynx. As we see, both with the laryngoscope as well as our exterior cameras, I have an entirely full mouth of airway contaminant made out of artificial blood. I'm going to begin to suction, and as you can see, I'm coming in. If I have active CPR in progress, I'll turn my catheter a little bit more laterally this way so that I can stay out of the way of the rescuers doing CPR. I'm going to evacuate progressively to the posterior palate. We're beginning to see the uvula now come into view. I'm going to do this very, very slowly. Don't take this as the speed at which I would do this clinically. Obviously, I'd be doing this much faster, but how can you learn anything if I do this too quickly, right? So here we go. James has given me a couple pumps on the airway contaminant lever over there. I'm seeing the tip of the epiglottis. As I see the tip of the epiglottis, I want to stay against the base of tongue. I want to stay against the base of tongue, and I want to go into the vallecula. I'm going to drain the pharynx. Now, I didn't show you how I use the suction catheter to help me put the laryngoscope in, so let me back up and do that for a moment. James, fill her up again, would you, bud? And that's good enough, dude. Okay, here we go. What I'm going to do is not only just suction, but you're going to see me actually use this like a laryngoscope where I push and lift. Now I'm compressing the tongue into the thyromental gap, and I'm distracting the lower mandible so I'm actually opening the mouth. I'm going to use a hybrid sort of overhand insertion method, now the standard insertion. And now, as I'm going to release the pressure onto the laryngoscope, now I've got a view of the hypopharynx. What I'm going to do is several very simple and easy to understand techniques in order to understand how to maintain airway decontamination. James, give me 3 pumps on the handle here. The reason I would want to leave the suction in during the intubation attempt is in the case of continuing airway contamination. If I'm not careful and I take the suction out, give me 3 pumps, 4 pumps, I'll have, that's it. I'll have a completely soiled airway, and now as you can see on the video monitor, I can't see the larynx at all. This would be a completely blind intubation. So how am I to manage this? If I leave the suction catheter on the right side of the laryngoscope, it's going to produce a problem where I now have difficulty of tracheal tube delivery. How am I going to leave the suction catheter in the mouth while I do tracheal tube delivery? There's 2 sides to the blade. I'm going to take advantage of the left side of the laryngoscope blade. I'm going to remove the catheter and place it down the left margin of the laryngoscope blade. So James, give me 3 pumps on the handle. And as you can see, what's happening now is that my suction catheter is taking up the lion's share of the airway contaminant. My next maneuver to create room for tracheal tube delivery, I've called the salad poke. With a single index finger, I can change the course of airway management. I simply place it into the pharynx alongside the right margin of the laryngoscope blade, and what I'm doing essentially is a dilatation maneuver. Not too much unlike when you're placing central lines. You don't try to place a central line over a guide wire without dilating. Why are you putting a tracheal tube into a patient without essentially determining and establishing space for tracheal tube delivery? With the removal of the salad poke finger, I'm just going to place the bougie. The bougie goes in, the tail comes out of the bougie, and the tube goes in. If you're using bougies, it is quite possible to get away without a salad poke, but I think you're really asking for trouble because you might have to use a stylet, or things just might not work out your way. As you can see, if I limit my space for tracheal tube delivery, what actually can happen is I can see what I want and I can't get it. That is like the biggest complaint with using video laryngoscopy. You can see it, but you can't have it. Why don't you do what we do in America? We have it all. We stick our finger in, and we get what we want. Now I'm going to release the tail, and now I'm going to advance the tube. And the most important part of this that you'll see on the video monitor is if I place the tube just in the neutral position, I can't get it in necessarily because there's a left cut bevel on this tracheal tube. It is going to increase some space between the bougie and the tip of the leading bevel, and it's going to trap the right corniculate. The larynx is shaped like a gorgeous large-mouth ice cream cone. It has a very large raised back portion, and it narrows to an anterior dished-out scalped portion. If you don't left turn the bougie, I call this, according to what a motorcycle rider might call it, I call it roll on the power. As you advance the tube, roll on the power. Yeah. What I can now do is I can trap the tracheal tube with my thumb, and I can take my own bougie out because I took my time and I rolled on the power. Now I have a contaminated airway. Do I want to ventilate this airway? I think I want to suction it before I ventilate it. So what I'm going to do is I'm going to go ahead and take my video laryngoscope out, and I'm going to run a flexible suction catheter down this tracheal tube. This is a nice, big, juicy 18 French suction catheter. The bigger, the better. Notice that I'm leaving the rigid suction catheter in and transferring it over to the flexible. Why did I do that? I'm not assuming I'm going to have a lot of help when I do this, and if I disconnect this prematurely, gravity for some reason increases its force during airway management and everything ends up on the ground. If I do it this way, I don't lose anything. And I place my finger over this and I drain the lungs and I draw this out of the patient. And now I can ventilate my patient, inflate my cuff the whole bit. I should have inflated the cuff before that, but I'm not going to do that in this demonstration.